Good morning. My name is Joshua Davis, and today I will be doing a presentation, a case study on chronic obstructive pulmonary disease, COPD, better known as COPD. The pathophysiology of COPD is its characteristic at being a progressive disease that limits the airflow through inflammation of the bronchial tubes. That is also known as bronchitis. It also causes destruction of alveoli, and that condition is called emphysema. Individuals who develop COPD have an abnormal response to inhaling toxin agents such as cigarette smoke. The amplified response to toxic agents results in mucus hypersecretion. With the mucus hypersecretion, the result of that is the destruction of alveoli because the mucus is very acidic, and mucus carries a lot of toxins, and it's trying to carry toxins out of the body. And so when you have excess amounts of mucus built up in the body, particularly in the respiratory tract, you're going to have destruction of different type of cells, particularly alveoli, because of the high acidity of the mucus. The primary cause of COPD is cigarette smoking, and COPD is the third leading cause of death in the United States. Common symptoms associated with COPD are shortness of breath, chronic cough, wheezing, fatigue, and frequent respiratory infections. An individual with COPD kind of becomes more prone to contracting respiratory infections because of this disease condition and the body's immune response to COPD. Nutritional risks associated with COPD are inadequate food intake, loss of appetite, malnutrition, lean body mass, and muscle loss. Malnutrition is pretty prevalent in COPD patients, and this is because COPD patients normally experience a lot of fatigue, and the fatigue from the condition makes it very difficult for patients to get adequate amount of food intake, and also the condition also can suppress the patient's appetite, which these results in malnutrition, lean body mass loss, and also muscle loss. Malnutrition and COPD. Malnutrition due to COPD can weaken the respiratory muscles, resulting in altered ventilation, poor immune function, and poor muscle strength. To identify a COPD patient, you would have to do a nutritional risk and nutrition assessment, which will be done during this presentation. Some individuals that suffer with COPD experience hypermetabolism, and this is pretty prevalent in COPD patients with the metabolism having hypermetabolism, and this results in lean body mass loss and also muscle mass loss through hypermetabolism. Okay, so for this case, we are doing a case assessment on a 62-year-old woman. Her name is Louise Hoffman. Ms. Hoffman has been diagnosed with stage 1 COPD 5 years ago. She's also have a smoking history of 46 years of smoking, but she has quit smoking over the past year. Ms. Hoffman has been recently admitted due to shortness of breath and a possible respiratory infection. Ms. Hoffman has a history of bronchitis and upper respiratory infections. She has 4 children. She lives with her husband, and she also has about 4 different family members that passed away because of cancer. Labs. Okay, so in Ms. Hoffman's lab, we noticed that her carbon dioxide and bicarbonate levels are increased. This is indicative of respiratory acidosis. She also has increased, well, a low albumin and protein levels, and that can be indicative of malnutrition. She has low hemoglobin, RBCs, and low hematocrit levels, and this is indicative of anemia. And she also has increased white blood cells and lymphocytes, and those are indicative that her body is trying to fight off infection from COPD and excess mucus buildup. She's currently taking Combivent. Combivent is an inhaler that she used for her COPD condition. She takes this medication 4 times a day, or 4 times a day, and each time she does 2 inhalations. She's also on Ncef, which is an antibiotic used to fight bacterial infection in the lungs, and she's also on Solomdrol, which is a steroid used to reduce the inflammation around the bronchioles. Food and drug interactions with her medication. Solomdrol has a food drug interaction with grapefruit juice. This could increase her blood levels of Solomdrol, and that may be an issue with her condition. Combivent has different side effects associated with sore throat, cramps, and nausea. And the medication Ncef is normally manufactured with high amounts of sodium, so that can be an issue as well. And people need to be mindful of that. Okay, so nutritional focused physical exam hasn't been done on Miss Hoffman. However, she did share with us her food history. Ms. Hoffman states that her appetite is poor. She kind of loses her appetite after she cooks, and she's always fatigued, especially when she has to prepare a meal. She doesn't really want to eat the food after she's done. And she also states that the food that she eats has like a real bitter taste. So like the flavor of food for her has changed due to her condition.
Our internet because it's messing up. So when students come in, if they have to take a test, I would send them to a different
Her 24-hour recall consists of a half cup of coffee. She has a sip of orange juice. She drinks a lot of 32-ounce Pepsi, half cup of oatmeal, and a 3/4 cup of chicken noodle soup and 2 saltine crackers. She also states that she tries to avoid milk because people tell her milk increases mucus production, and she doesn't have any nutrition therapy on file. Ms. Hoffman, anthropometrics are, she's 5'3", 119 pounds. Her BMI is a 21. Her usual body weight is 145 to 150 degrees, and her last reported weight was 139 pounds. So for Ms. Hoffman, I came with these 2 different diagnoses, which I stated that in my PES statement that Ms. Hoffman has inadequate energy intake related to decreased ability to consume sufficient energy intake, as evidenced by patient claims of being too tired to eat after cooking. Ms. Hoffman also had a diary call done, and it was revealed in her diary call that she only consumed about 1,070 calories, and so that's well below what her daily calorie needs are. She also has inadequate protein intake related to poor appetite, as evidenced by her 24-hour diary call, and we estimated that she may need about 95 to 110 grams of protein a day. nutrition intervention goals. The goals is to get Ms. Hoffman consumption of Pepsi down to maybe cut it down maybe about 12 ounces for a month. That'll be a good start. We also would like to see Ms. Hoffman increase her protein to 95 to 110 grams per day. And we want her to get her calorie intake up to about 2,100. According to her ideal body weight, her K-calorie requirements are only about 16 to 1,700 K-calories a day. But if we get her K-calories up to 2,100 calories a day, then we may start seeing progress for us, her weight gain and muscle mass gain. And the monitoring evaluations, we're going to use food journals and diet recalls to evaluate what Ms. Hoffman has been eating, and we're gonna periodically check her BMI to see if there's any progress being made, and her weight will be recorded after each follow-up. And that's the conclusion of my presentation. I hope you guys enjoyed it.